So again, today we have today we'll be going over eating disorders in youth as part of our 3D echo. And I'll go ahead and get started. I'm sorry there's not a bigger turnout. I won't belabor too many of these points, and we can open up for questions. So we'll make it feel more interactive. Um, so any disclosures? The only disclosure I have is sort of partner here at Frontier Psychiatry. Otherwise, none. I'll just kick right off into kind of the DSM-5. DSM-5 contemplates a number of different uh, eating disorders that were some of which were already in the DSM-4, and there were some changes. But just going briefly, and again, these are slides I'll be sharing with everyone. Is you have anorexia nervosa, right, and that's where you have really restriction of calorie intakes. And then that leads in turn to low body weight for age, sex, and projected growth, and deteriorating physical health. And associated with that, you have an intense fear of gaining weight or behaviors that interfere with weight gain, even though they're already at low weight. And then lastly is is sort of an altered, distorted perception of one's body weight or shape. And then constantly focusing on body weight shapes as a reference point for self-value. And then certainly kind of lack of insight is another big piece of the puzzle. And there's several subtypes, and I won't go into the details there. But again, big picture, anorexia nervosa is one of the diagnoses. Next, bulimia nervosa, and this disorder is associated with repeated episodes of binge eating. It includes sort of eating within a specific amount of time, usually short duration. Here they say, give you an example, around 2 hours, eating more than what's normal for that size individual, and what would normally be eaten during that period of time under similar circumstances. And a feeling that person will have that they can't limit or control their overeating while they're doing it. Then there's some compensatory activities or behaviors that go along with that, including self-induced vomiting, misusing laxatives or diuretics or other medications, restricting or fasting, and exercising too much. And on average, the binge eating, along with the other side of that, the compensatory behaviors, occur at least once a week for 3 months, and is similar to anorexia nervosa. The self-value is very closely linked to body shape and weight. And what's another key piece of this is that the binge eating and compensatory behaviors don't exclusively happen during episodes of anorexia nervosa. Binge eating disorder. So this is kind of, again, repeated episodes of binge eating. Similar definition where you're eating sort of larger than typical amount of food in a short period of time. They include 3 or more of the following components as well. So eating much more quickly than normal, eating until uncomfortably full, eating large amounts when not feeling hungry, eating alone because of embarrassment at how much someone's eating, feeling guilty, disgusted, and depressed afterwards. Then associated with that is a lot of anguish, especially during the binge eating, during and after those episodes. And on average, the binge eating occurs at least once a week for 3 months for this big diagnosis. And again, the binge eating is not associated with the use of inappropriate compensatory behaviors like in bulimia nervosa, and it doesn't occur only in the context of either one of these disorders. So again, you have anorexia nervosa, bulimia nervosa, and then binge eating disorder. And the principal difference between bulimia nervosa and binge eating disorder is kind of the lack of these compensatory behaviors. Then you have avoidant restrictive food intake disorder. This is kind of a disrupted pattern of eating. And some examples are kind of not being interested in eating or in food. And the avoidance is not so much based on kind of how they feel about their body, but it's on sometimes can be on the sensory qualities of the food, or worried they have kind of a fear of that they'll throw up after eating. So it's not associated with like I said, body image and self-worth around kind of the body shape. And associated with that is kind of ongoing failure to meet energy needs, leading to significant weight loss, or in kids, you'll have below expected growth or weight gain, nutritional deficiency, reliance on on enteral feeding, in other words, kind of tube feeding, and oral nutritional supplements to kind of make sure that the right nutrients are ingested. And definitely, as any DSM disorder, there's significant interference with psychosocial functioning. Um, the then the other kind of part of this is that the disturbance can't be better explained by lack of available food or by cultural factors. And then and again, sort of the last element of this is it can also is not it's also not associated with any type of medical condition. And then one of the things that changed in the DSM-5 is you no longer have eating disorder NOS. Instead, you get what's called other specified feeding or eating disorders. And here's some examples. One is atypical anorexia nervosa, where you have all the criteria that are met, but a person's weight is within or above the normal range, even though there was significant weight loss. So again, the person may have been overweight and went down to quote unquote normal weight, but it's still anorexia nervosa. Another kind of other specified feeding or eating disorder is um, bulimia nervosa of low frequency or limited duration. So you meet all those criteria, but on average, this happens less than once a week, or happens for less than 3 months. Next is binge eating disorder of low frequency and limited duration. Same thing. Meets criteria except the frequency and duration criteria, which so it would happen less than once a week and for less than or fewer than 3 months. And lastly, purging disorder. You have kind of recurrent purging disorder behaviors, which include self-induced vomiting, misusing laxative, diuretics, or other medications, but you don't have the associated binge eating with the intent to influence weight or body shape. So what's the scope of the problem? So lifetime prevalence can be up to 22.7% in females. So this is throughout the life. And clearly big difference, 0.6% in males. According to a 2011 survey of 10,000 U.S. adolescents aged 13 to 18, here was the relative prevalence rates. Anorexia nervosa 0.3%, bulimia nervosa 0.9%, and binge eating disorder 1.6%. And the mean age of onset for these eating disorders was 12 and a half years of age. And likely, binge eating disorder is the most common eating disorder in youth, with prevalence rates up to 4%. So who's at risk? Well, these are two example groups of that are most at risk for developing eating disorders. One, you have sexual minority youth that include lesbian, gay, and bisexual high school students. Also, there was a survey of 300,000 college students that uncovered that transgender students had highest rates of self-reported disordered eating. It turns out nearly 16% of transgender respondents reported having been diagnosed with an eating disorder, compared to less than 2% of cisgender heterosexual women. Youth with chronic health conditions requiring dietary controls are also at elevated risk, including those with diabetes, cystic fibrosis, inflammatory bowel disease, and celiac disease. And interestingly, and something to keep in mind that for all of us that work with kids, among youth with type 1 diabetes, at least 1/3 may be engaging in binge eating, self-induced vomiting, insulin omission for weight loss, and excessive exercise. And all this leads to, as you can imagine, to problems regulating blood sugar. So there's some ways to kind of approach a targeted interview when in patients who you might be concerned will be experiencing and have an eating disorder. So just going to go over some basic components of that targeted interview. One is going over weight history. So here's some questions. What was your highest weight? How tall were you and how old were you? And then what was your lowest weight? How tall were you? How old were you? Again, this allows you to get sort of a range of weights associated with that particular person. Next, you go from weight history to body image. What do you think your weight should be? What feels too high? What feels too low? Are there body areas that cause you stress? Which areas? Do you do any body checking? For example, weighing, body pinching or checking, mirror checking? And then how much of your day is spent thinking about food or about your body. Next area of inquiry could be diet history. Ask about the 24-hour diet history. What did you eat? What did you consume? What did you drink? What did you ingest over the last 24 hours? Do you count calories, fats, or carbohydrates? How much do you allow? What foods do you avoid? Do you ever feel guilty about eating? If so, how do you deal with that guilt? Do you exercise, purge, eat less? Do you feel out of control when eating? Next, asking about binge eating and purging. So, question: do you ever binge? On what foods? How much? How often? Are there any triggers? Next is: do you vomit? How often? How soon after eating? Then asking: do you use laxatives, diuretics, diet pills, caffeine? If so, what types? How many and how often? Family history. Does anyone in your family have a history of dieting or an eating disorder? Anyone on special diets, like vegetarian, gluten-free? Anyone with obesity? Does anyone in your family have a history of depression, anxiety, bipolar disorder, obsessive compulsive disorder, substance abuse, or other psychiatric illnesses, right? So basic psychiatric history. And then finally, does anyone in your family take psychiatric medication? Next is a review of systems that, again, designed to elicit kind of responses that are associated with eating disorders and the physical symptoms. So any dizziness, syncope, weakness, or fatigue? Is there pallor, easy bruising or bleeding, cold intolerance, hair loss, lanugo or dry skin, constipation, diarrhea, early fullness, bloating, abdominal pain, and heartburn? Asking about palpitations or chest pain, muscle cramps, joint pains, excessive thirst, voiding. And for girls, asking about age at menarche, frequency of the menses, last period, and what was the weight of at the last period. So when it comes to interventions, the American Academy of Child and Adolescent Psychiatry, that's what ACAP is. Recommendation 1. So mental health clinicians should screen. So this comes from these recommendations come from the treatment guidelines. Mental health clinicians should screen all child and adolescent patients for eating disorders. Number 2, a positive screening should be followed by comprehensive diagnostic evaluation, including lab tests and imaging studies as indicated. Right. Again, this is to address the frequent medical comorbidities that are associated with eating disorders. Recommendation 3, severe acute physical signs and medical complications need to be treated. And in many cases, you can imagine if they're severe or they're acute, hospitalization is indicated. Number 4, psychiatric hospitalization, day programs, partial hospitalization programs, and residential programs for eating disorders should be considered only when outpatient interventions have been unsuccessful or are unavailable. So again, the whole idea there is trying to keep folks in the least restrictive level of care. Number 5, treatment of eating disorders in youth usually involves a multidisciplinary team that is developmentally aware, sensitive, and skilled in the care of children and adolescents with eating disorders. So again, multidisciplinary it's always a good thing to consider, but especially for these disorders that includes so much of both mind and body. And again, eating disorders, as you can imagine, are one of the most patients with eating disorders are one of the most medically compromised groups of patients in psychiatry, as you can imagine, and the other ones tend to be folks with alcohol use disorders. But again, these are the major organic insults through eating disorders. Number 6, outpatient psychosocial interventions are the initial treatment of choice for children and adolescents with eating disorders. And then if that fails, then or we're having problems with treatment, consider using medications, including complementary and alternative medications. And these should be reserved only for comorbid conditions and refractory cases. So again, as you can imagine, people who struggle with eating disorders will often have comorbid psychiatric disorders, including anxiety, depression, and others. In terms of the types of interventions, so there's family-based therapy or family-based treatment, which is essentially family-based therapy that supports parent management of eating and related behaviors until adolescents are able to show improvement. So this is an approach that really demands that parents get heavily, deeply involved. Can be useful for most cases of short duration anorexia nervosa or bulimia nervosa. And there have been 6 randomized controlled trials that support the efficacy of this intervention for anorexia nervosa. It's not been compared sort of head-to-head with other treatments, and there are 2 randomized controlled trials supporting that this approach is good for bulimia nervosa as well. Then there's adolescent-focused therapy, and the goal of that therapy is to target autonomy and self-efficacy during adolescent development. Can be used for adolescents who have anorexia nervosa when family-based treatment isn't feasible. And this treatment has been subject of 2 randomized controlled trials. It was effective, but fell short of the results of family-based therapy. Interpersonal psychotherapy. So interpersonal psychotherapy focuses on changing problematic interpersonal relationships that trigger or maintain eating disorder symptoms. So again, this addresses relationships, right? Other therapies target individuals. This targets relationships. And actually, I would say, well, family-based treatment also targets relationships. So, so you'll see there's a pattern here that relationships are key, and that's often the case with any with a psychiatric disorder. Kind of problem relationships tend to exacerbate the problem. Interpersonal psychotherapy is useful for case of bulimia nervosa and binge eating disorder as an alternative to cognitive behavioral therapy. There have been 2 randomized controlled trials in adults with bulimia nervosa as well as binge eating disorder, and these results support the use of IPT for these conditions. And there's preliminary data showing that IPT is useful for adolescents with binge eating disorder. Antidepressants can be helpful for symptoms of obsessionality, anxiety, and depression related to anorexia or bulimia nervosa. Targets binge eating and purging in bulimia nervosa. Can also be useful, as I suggested before, for comorbid disorders like anxiety, depression, and can be considered a second-line treatment for adolescent binge eating bulimia nervosa. There was 1 uncontrolled trial suggested antidepressants are tolerated and may be helpful for adolescent bulimia nervosa. But big picture, I would tell you that antidepressants, and if your target is to treat the eating disorder, antidepressants aren't that great. Again, if there's comorbid anxiety, depression, that's when you want to bring it in. Atypical antipsychotics can be introduced when there's significant and severe body image distortion, weight gain fears, and anxiety related to anorexia nervosa. And again, like any medication management in the context of eating disorders, you probably want to save it for comorbid conditions, but really the further study, and this is kind of a nice way of saying that we don't know if it really works for the core symptoms of anorexia. There's been some thin research available, case series, data from case series, and 3 pilot randomized controlled trials indicate that there's really insufficient evidence to suggest that atypical antipsychotics are useful for anorexia nervosa. And that's it. Any questions?
Actually, I have a question.
Yeah.
There's a lot of talk about the role of social media in teens and preteens body image. Has there been a corresponding increase of any of these eating disorders with as much attention that's being paid to social media these days?
That's a great question. I've not seen that there's been necessarily an increase in the prevalence. But you know what? Let me take a look real quick. So prevalence rates of eating disorders in youth. Let's see. Not seeing anything in terms of increase. So yeah, I'll have to do a deeper dive. But I think the point you bring up is a very good one. There's one patient I had, it was a teenage girl who struggling with an eating disorders during the pandemic. Actually, I heard about a bunch of girls struggling with eating disorders during the pandemic. I think we all struggle in one way or another, but the same girl actually recognized that social media was a trigger in some way, and so actually made a concerted effort to stay away because it caused just getting on social media caused such distress. And she connected the two.
Mhm.
And so she had the insight to kind of step away from that. But yeah, but I don't know in terms of the prevalence rates if they're kind of going up because of eating disorders or not. But I wouldn't be surprised.
Yeah, thanks. I mean, I would just think that maybe it doesn't manifest itself necessarily in perhaps an eating disorder, but perhaps the beginning with depression, anxiety, that
Yeah, but no, but you're also right. I mean, it's if you're vulnerable already, right? If you're vulnerable to having anxiety or depression, in general, you're going to be probably more vulnerable to other disorders, including eating disorders.
does anybody else have questions or a case that they would like to discuss?
And I'm just looking here. I did find a study that does report an increase. The prevalence of eating disorders increased. So they took two periods. They took 2000, the 6 years from 2000 to, or the 7 years from 2000 to 2006, and compared it to the 6 years from 2013 and 2018. And the prevalence rate more than doubled. It went from 3.5% to 7.8% in the studies.
Wow, that's pretty
So
significant.
yep, that is very significant.
And
So
then
yeah,
I just have another question too.
sure.
I would assume that schools, way back when I went to school, we got weighed in public, all that fun stuff. But, are school counselors, teachers, do you know if they have triggers or some way of I'm just trying to think of ways to get early recognition of symptoms.
So um, so there's no great sort of broad-based or training program for teachers in the way we'd like to see, as you can imagine. But I can tell you there have been a couple situations when I was working with girls, again because girls tend to present more than boys with eating disorders. I I had a couple situations where the moms, well, the family, actually, no, the couple was like where both parents actually they had a good relationship with the principal of school. The principal of school was someone who would kind of go to the lunchroom, um, and they spoke with the principal as well as kind of the guidance counselor and just said, "Hey, here's what we're struggling with. Can you just keep an eye on things? Make sure she's eating. See if she's throwing the food away." Just just again to get more data and just knowing that because again the power of a caring adult in the school I think is also is critical, but also having another set of eyes in the school is great if it's done well.
Mhm.
Obviously it needs to be done very delicately, but I guess that's the way that I've seen kind of collaboration with school used well.
Mhm.
But again, it's the topic of weight and body image and eating disorder is so charged with, especially with the individuals, because of I mean, part of the disorder is lack of insight, right? Part of it is saying, "No, I'm fine. What are you talking about? I'm totally fine." So so having that conversation can be very difficult, and that's why family-based therapy is kind of an aggressive approach, but outcomes have been quite positive because really the idea is, look, you're not you're not in a place to manage your own diet and manage your own food intake. You're just not. And until you are, parents are involved. And maybe that's not some people might not say that's not the most sort of patient-centered approach, but on the other hand, it's effective. And if you're in a place where you can't really rely on that person to make sure they're getting the right nutrients and energy, caloric intake, caloric needs met, then you got to do it.
Mhm.
It's interesting in the article, the article kind of just pulled up and looking at the prevalence rates. Actually did mention that the pandemic and isolation in general tend to be can be fertile ground for the development of eating disorders. And again, another kind of thing to think about is asking. One of the things that wasn't in this presentation that I will do and have been sort of trained to do is asking about not only kind of an individual's relationship with food, but also the family's relationship with food, right? So is mom or dad super into like being, vegan or vegetarian, or they tend to be, sort of over exercise and kind of, and that can people talk comfortably about food around the family, or do kind of things come up where a mom or dad's like, oh, I never do that, or I shouldn't do that, or because that starts having an impact on the child's relationship with food as well. So anyway, so asking about a person's relationship with food can be useful, especially a family's relationship with food.
Yeah.
Other questions or comments or other cases? And again, I've in treating eating disorders, I've rarely come across a situation where medication does much to the core eating disorder. I mean, there was some thought initially when they started using trying to use antipsychotic medications for the treatment of eating disorders, because the idea was, wow, these folks aren't entirely connected to reality. They don't really see what's going on, so maybe an antipsychotic would help. It doesn't help. The antipsychotic, what it does is it takes the edge off of sort of the anxiety and the level of distress, but it doesn't lead to insight. It doesn't lead to them going, oh, now I see what you're saying. Like that doesn't happen. Anybody else? All right, I will. What I'm going to do is I'm going to download these slides right now, and I will send them along so that they can be shared.
Okay. We'll
Cool.
get those out next week with the recording. And just to remind everybody that if you have missed a session that you would like to review, they are all on our website, and I'll follow up with an email to the group next week.
Great. Thanks, everyone.
Okay, thanks.
Bye.
Bye.